Well, hi everyone, welcome. I'm Michael Morella, Managing Editor at US News and World Report. Today's session, will examine customizing care for complex pediatric cardiology patients. We have a range of experts in cardiology and oncology who will share their insights about the intersections of those fields and other areas in the pediatric patient population. To start us off, I'm going to turn it over to my colleague and US News Managing Editor Liz Whitehead for a conversation she hosted with Dr. Daniel Bowers of Children's Health and UT Southwestern Medical Center. Let's take a look.
Joining me today for this conversation is Dr. Daniel Bowers, a pediatric hematologist and oncologist at Children's Health and a professor at UT Southwestern Medical Center. Welcome, Dr. Bowers.
Hello.
You and your colleagues have been doing some exciting work on developing new approaches to help mitigate the impact of cancer treatments on young patients, particularly cardiovascularly. Can you sort of set the stage for us and talk about, first of all, how big a population of young cancer survivors are we talking about?
Yeah, so every year in the United States, there are about 16,000 children diagnosed with cancer. And although that number may seem somewhat small, in fact, about 85% of those children diagnosed with cancer will become long-term survivors. And so, in fact, that is a huge population, and that's a growing population. In fact, as of the year 2025, there are more than 500,000 survivors of childhood cancer in the United States. And so, as this population grows, it's becoming increasingly recognized that these survivors of childhood cancer are at risk of developing certain long-term complications of their cancer.
So can we zero in on what some of these are? What kinds of long-term cardiovascular damage can pediatric patients experience from their treatments?
Yeah, so cardiovascular injury is among the most common long-term complications of cancer, and in fact, among the most serious. In fact, cardiovascular complications are the leading non-cancer cause of death among childhood cancer survivors. And so this is a huge problem, and a problem that we are focused on in trying to both diagnose and trying to relieve the severity of these complications.
And what are some of the major complications, cardiovascular, cardiomyopathy, or can you talk about some of those?
So cardiomyopathy is by far the most common cardiovascular complication, but there are other complications as well, including things such as rhythm problems, pericarditis, damage to the coronary arteries, things such as that. In fact, it's been recognized that being a cancer survivor and having been exposed to chemotherapy and radiation, this induces a premature aging phenotype. And so we are seeing severe cardiovascular disease in children in their teens that ordinarily would not be apparent until people are in their 50s, 60s, and 70s. And so we feel it is critical to diagnose this early so that we can do something about it.
So you have put together multidisciplinary teams, and I want to sort of break this into two parts. The part when the treatment is underway, and then how the patient is treated, how you monitor the patient after treatment stops. Can you talk about how you might work, well, as an oncologist yourself, how you work with the treatment specialist to try to modulate how each patient gets their treatment?
Yeah, so we are learning more and more about the risk factors for developing heart damage associated with cancer. And among the risk factors include chemotherapy exposure, specifically anthracycline chemotherapy such as doxorubicin or daunorubicin. Also, radiation exposure to the heart is also contributes to the development of heart damage. And the combination of anthracycline chemotherapy and radiation exposure to the heart puts patients at very high risk of developing cardiovascular complications.
So how do you work with your colleagues to modulate the treatments while the chemotherapy, for example, or radiation treatments are underway? How do you modulate them for each individual patient to sort of limit some of these harms?
Right. So for patients undergoing therapy, we will modulate their therapy or adjust their treatment to lessen the exposure to anthracycline chemotherapy. Furthermore, we will use medications that protect the heart from anthracycline chemotherapy. And then finally, we know that radiation therapy causes damage to the heart, and we will sometimes use proton radiation, which can target the tumor but limit radiation exposure to the heart. And so these are strategies that we use for patients to design their treatment plan to protect their heart. After finishing treatment, we follow patients in our cardio-oncology program. So as I mentioned, we've identified risk factors for developing heart damage as a result of cancer therapy. We believe in a personalized approach. And so patients who have exposures that put them at risk of heart damage, we follow them in our cardio-oncology program. This includes regular follow-up with a cardiologist as part of standard survivorship care. When we started this cardio-oncology program in the year 2000, care was fractured. Care was not organized in a systematic fashion. Patients would see their cardiologist periodically. They would see their cancer survivorship specialist occasionally, but there was not any crosstalk between these two disciplines. And when we founded our cardio-oncology program, we have the cardiologist and the survivorship specialist in the same room where patients are being followed after cancer treatment. We also include psychologists and nutritionists because we believe these are also very important disciplines to be included in the long-term cardio-oncology care of our patients.
So one of the obvious benefits of this is I would assume for the families that they're not required to set up appointments at different locations, different times, and then also the medical records exchange. And then I think you're also suggesting there's just better communication between the specialists.
Yes, this is in some ways one-stop shopping. So for families, this is much more convenient. They're able to come to the hospital for their follow-up care once a year, perhaps twice a year, where they will see all of the specialists who are involved in their child's care in one visit. But this also improves care because it improves communication between the survivorship specialist as well as the cardiologist. But thinking for the future, it's important to include things such as nutrition, because nutrition has such an important role in preventing heart disease. And so all of these visits occur in a single afternoon. We also have participation by psychology because we know that these patients often have increased risk of psychological distress and anxiety following their treatment. And so again, this is one-stop shopping for families. We have received nearly universal enthusiastic support from the families for our program.
So I may be restating the obvious, but it seems that when you're talking about risk factors for things like cardiomyopathy or other cardiovascular problems, is it accurate to say you're trying to limit the other factors that can exacerbate these problems? These are things in your control.
Well, so yes, exactly. So there are some things that are not in our control. And so, for example, the diagnosis of cancer is something that we're not able to control, but we are able to limit exposures that would be causing cardiovascular damage. And then after treatment is finished, we're able to monitor patients closely. We're able to provide them with a personalized plan for monitoring and intervention by a specialist who sees hundreds of cancer survivors who've been exposed to cardiotoxic medications and radiation. And so, instead of having just a ad hoc or one-off cardiology visit by a cardiologist who has lots of other interests, this is follow up with a cardiologist who has a dedicated interest in the long-term complications of childhood cancer.
Now, I think that your one of your goals is to try to make your results as duplicable nationally as possible. Can you talk a little bit about, I think you published a study in 2024, and what are your plans? And that is what reflects 4 or 5 years of this
Yes.
program,
Yes.
and then what your plans are to publish your next results, and what did you find for 2024, and what do you hope to be able to report in terms of results?
Right. So, in the adult cancer world, cardio-oncology is a established discipline. But in pediatric cancer survivorship, it does not exist. And so in the year 2000, we partnered with our colleagues in pediatric cardiology and created the first ever dedicated pediatric cardio-oncology program. And we learned a lot in this experience about what the best way to organize this program was, and who to include, and how to get engagement by all of the stakeholders, including the cardiologist, the oncologist, social work, psychology, nutrition. And so we crafted this clinic and put it together and started seeing patients. And then we learned, as through the process of seeing patients, of what things worked and what things did not work. We summarized this and published this in a scientific journal back in 2024. And this serves as a blueprint for other pediatric cancer programs to establish their own pediatric cardio-oncology program.
And would it be fair to say that when, it's not inexpensive to try to, bring in nutritionists and psychologists and other specialists, but when you're talking about long-term survivorship, isn't this a really important thing to do, not only just to make sure that the kids thrive in adulthood, but also the medical costs if you stave off some of these major consequences of treatment?
Right, absolutely, absolutely. And so, for example, there are risk factors for cardiovascular disease in adults, such as hypertension, insulin resistance, elevated triglycerides and cholesterol. And nobody was paying attention to these things in childhood cancer survivors. And especially in the high-risk population who had been exposed to anthracycline chemotherapy and radiation. And so our program brings together nutritionists who can counsel families and counsel patients about their risk, and with the goal of reducing those risks. And of course, we also include counseling on exercise and weight loss, knowing that these factors will also contribute to early onset cardiovascular disease.
Well, this is very encouraging. Dr. Daniel Bowers, thank you very much for sharing your time and these really hopeful advances that will ensure the kids not only survive childhood cancer, but actually go on to live fulfilling lives as adults. Thank you very much.
Thank you.
Thanks to Dr. Bowers and to Children's Health for their support of today's event. Now I'm very pleased to introduce our panel, who I invite to return to the screen. With us today, I'm very pleased to introduce Dr. Alfred Asante-Karang, Director of Heart Transplantation, Cardiomyopathy, and Heart Failure at Johns Hopkins All Children's Hospital, and an Associate Professor in the Division of Pediatric Cardiology at Johns Hopkins University. Dr. Nathania Baez-Hernandez, Pediatric Heart Failure and Transplant Cardiologist at Children's Health and UT Southwestern Medical Center, where she's also Cardio-Oncology Medical Director. And Dr. Seth Hollander, Pediatric Cardiologist and Medical Director of Heart Transplantation at Stanford Medicine Children's Health. Thanks so much for making the time to be with us, the three of you. Before I kick off the conversation, I want to say to those of you in our audience who are with us live today, if and as you have any questions, please feel free to enter them into the Q&A feature in Zoom on your screen. Our team will review and try to incorporate some of those before we wrap up. I also want to say that we are recording video of today's session, and we'll be making that available. Look for a follow-up email from our team. Now let's get started because we've got a lot of ground to cover. Dr. Bowers set us up nicely with a lot of insights and details that I want to come back to over the course of our conversation. But I'd love to start if you could each sort of tell us a little bit about your role, and really your roles and your work at the intersection of cardiology and oncology at your different institutions. Dr. Ake, maybe we could start with you, and if you wouldn't mind telling us a little bit about how the cardio-oncology program at your institution got started, and how you work at the intersection of those specialties.
Thank you. Good afternoon, and thanks for inviting me to this important webinar. This is a very, very important, program for our institution. We take this program very, very seriously because of the implications for long-term survival of these patients. Our program is actually a collaboration between our oncology department and bone marrow transplant programs on one hand, and our heart failure cardiomyopathy program and our cardiology program on the other hand. We started this program in 2022, and we have now developed an inpatient consulting service as well as an outpatient clinic program together with our oncology colleagues. Both services are provided by the heart failure cardiomyopathy physicians and advanced practice providers. On the oncology side, Dr. Jennifer Dean leads the cardio-oncology program from that side.
Dr. Baez-Hernandez, could you do the same? Talk a little bit about your cardio-oncology program. Again, we heard some from your colleague, Dr. Bowers, but would love to hear about you and your work.
Absolutely. So I am Dr. Baez-Hernandez Natanja, and I have the privilege of serving as one of the cardiologists lead for this cardio-oncology program. You heard a lot from Dr. Bowers how we kind of run our program, but essentially in 2019, we developed this idea of developing a cardio-oncology program, and the idea happened that I was during my training for heart failure transplantation. I developed this special interest in this patient population. So we just partnered with Dr. Dan Bauer and Dr. Senya from oncology. They are the one that kind of lead after cancer experience program here in our institution. And we started initially with them and partnered with them and developed this beautiful program here. During 2019, as everybody remember, that was the COVID era. And despite that, we started having these meetings, every month, virtual meetings. And by the end of 2020, October, we were able to launch our program. And since then, we have, and I would, tell you a little bit more later how our programs run, because we have advanced this program significantly, and our program works in different settings. But initially, we started with this outpatient setting, following patients just in the after cancer experience clinic. So it has been, of course, like Alfred said, is a program that is led mainly by cardiologists. We partner with oncologists, but also advanced practice providers. They are key members of our team. And I think like every cardio-oncology program that is happening in the country, pediatric, is mainly led by cardiomyopathy doctors. So as you see the panel here are 3 heart failure transplant cardiologists. So this is where we are now.
Wonderful. Thank you and welcome. Dr. Hollander, what about you? If I understand correctly, Stanford Children's is among the busiest transplant programs in the country, but does not have a cardio-oncology program specifically per se. Could you talk a little bit about that?
Of course. So at Stanford Medicine Children's Health houses the Betty Irene Moore Heart Center, which is a group of nearly 70 cardiologists that takes care of children and young adults with medical and surgical heart disease, and kids who need both. Within our heart center, we have a group called the Pediatric Advanced Cardiac Therapies Group, which is a group of 9 subspecialty cardiologists, of which I am one, that takes care of kids who are at risk for heart failure, meaning at risk for having a weak heart, something we call cardiomyopathy, kids with heart failure, and kids who've undergone heart transplants. And we perform over 20 heart transplants per year. We also take care of kids who require mechanical support to support the heart, usually as they wait for transplant. When I reflect upon it, there's really 3, I think, very important ways that we collaborate with the oncologists. First, as Dr. Bowers mentioned, kids who are cancer survivors, particularly those who've received medicines like anthracyclines or more recently medicines called MEK inhibitors, are at risk for developing heart failure and cardiomyopathy. And we work with them to take care of the hearts of these cancer survivors. Secondly, among kids who've undergone heart transplant, roughly 5% of them are at risk for developing a post-transplant cancer, which is a known risk factor of kids who've undergone organ transplantation. And the oncologists help us take care of our heart transplant patients who develop post-transplant cancers. And then thirdly, and perhaps most interestingly, we're really at the forefront of medicine working with our stem cell transplant doctors, who are really at the leading edge of learning ways of modifying the immune system to make recipients of organ transplants more tolerant, to make the immune system tolerate the organ to reduce the chances of rejection. And through some outstanding work done by my colleague, Alice Bertania in the stem cell department, we actually have a few kids who've undergone sequential kidney transplant and stem cell transplant who require absolutely no immune suppression whatsoever. And this is really a breakthrough and something we are currently working on to see if we can expand it to other organ transplants, including heart. Because really the holy grail of heart transplant and solid organ transplant medicine would be the ability to transplant an organ and not subject a child to immunosuppression and all of the side effects of that, including post-transplant cancers.
Thank you. Yeah, you've all touched on it, and as did Dr. Bowers. I think understanding some of that long-term damage that pediatric patients can experience from cancer treatments. I wonder if you could kind of break that down a little bit more. Cardiomyopathy, of course, is a big one. What else is there? And even more broadly, outside the cardiovascular realm, what are some of the considerations that you all might be working with specialists and colleagues across other service lines too? Maybe Dr. AK, you could start, or?
So apart from cardiomyopathy or acute ventricular dysfunction that the patients may develop during the cancer treatment, they can also develop heart rhythm problems. Sometimes significant heart rhythm problems that you have to move them from the cancer unit to one of the ICUs. They can also develop what's called myocarditis, which is or pericarditis, which is inflammation of the heart muscle or the sac surrounding the heart muscle. They can also develop what's called autonomic dysfunction. They may have periods where the blood pressure is too low, periods where the blood pressure is too high. and they can develop long-term, they can develop vascular lesions such as coronary artery injury. So there are multiple cardiac complications that these cancer patients can develop, both during treatment and after treatment. So it can be long-term. And then there's the other group of cancer patients who are undergoing bone marrow transplantation, who can also develop several complications that we help manage, including what's called cytokine release syndrome during the time of engraftment.
Please.
Michael, I know that this webinar is going to be a conversation that we are going to be talking about, of course, the cardiovascular complication that can happen in cancer patients and survivors, and how do we develop programs to try to improve the cardiovascular health in these cancer patients. And it's important to also emphasize that, because I'm not going to be repeating what Alfred just said, that our first goal is to get patients to cancer cure. Okay, so they have to survive their cancer, because sometimes this cardio-oncology plays a significant role in this first phase of how can we support patients to a successful cancer treatment. Because clearly there are patients that present to us with already some cardiovascular dysfunction because of the cancer, for example. Let's say a patient with neuroblastomas, or patient with Williams tumor and stuff. And then our role as cardio-oncologists, how can we help this patient to get first to a successful cancer treatment when they have already a compromised cardiovascular system, some problem, either heart failure or some other form of cardiovascular disease. Because sometimes you need our expertise to tell you, keep going. You have to keep going, because when you don't have that much expertise, people get a little bit nervous about, should we do this treatment for these patients or not? Because, the ejection fraction or something, the heart looks X, Y, and Z. So it is very important how, the role starts there. And like Seth was saying, that's why this kind of oncology, it works in a different platforms. You have, of course, the patients who are already in the hospital. Those are the ones receiving cancer therapy. And when we're talking about cancer therapy, I'm talking about either chemotherapy, radiation therapy, or those that are undergoing stem blood cells, and other stuff, transfusions and transplants. So then, of course, you have the expert, and like you also said, like on our program as well, is all this cardiomyopathy team, because we are the one who have the most expertise in cardiomyopathies, who are the one kind of leading the program, because in the past, general cardiology were doing that, but then they were just consulting at the end, the heart failure and transplant team. So that is why when we decided to develop this program, we say, okay, we're taking over, because at the end, we are the one managing this. And then we took the lead on that. And then, of course, once the patients get to go through this stage of treatments, we guide them how to support them through there. Either do they need medication to get through the treatment because the heart is weak to undergo chemotherapy, yes or not? And I think later on, we're going to be talking perhaps advanced support. Do they need more advanced support on the medications? So the field is evolving, and the more we learn about these patients, and as the heart failure field advance, we can also provide more support to this cancer population. And then you have the patients, of course, that are already become survivors. So then we know that finally they have survived this horrible disease of cancer, but then now we know that they are such a high risk of developing complications because of the cancer treatments. And those complications, of course, you can have early complications, acute, subacute, and then the chronic complications, right? The ones that people, fear the most are the ones that happen later on in life, because those are the ones, the acute complications, less than 1% of these patients perhaps have this complication, but the ones that you hear to talk about, these patients have 10 times more chances of developing heart failure, myocardial infarction than their age-matched cohort are those complications that happen later on in life when they are adults and they are not even followed by pediatrics anymore. You know, they might lose insurance in these kind of things. So addressing and preparing them for that life down the road when they becoming vulnerable at the end. So that is also that role that we as cardio-oncology, we have to start working on. So it is all these cardiovascular complications because people think sometimes like, oh, it is just the cardiomyopathy that happens, you know, down the road. So no, this field, that's why this is becoming you might argue, is cardio-oncology its own subspecialty? And at this point, perhaps in pediatrics, we cannot say that, but if you go to adults, you see, there is even, you know, program on fellowship and training to do that because the umbrella is so big, you know, from the acute, the diagnosis, primary prevention, secondary prevention, to then later on in life. And all these complications that my colleague Alfred, you know, mentioned already. So just putting this out there because we get a lot of consults about should we do anthracycline or not? Should we do this therapy or not? Or we doing these treatments and, you know, bone marrow CAR T-cell therapy. What should we monitoring for? You know, so what can we do to make this patient a better candidate? So that this active role of a cardio-oncology is extremely important.
Yeah, I agree with what both of my colleagues say. I think the only thing I could add or reinforce is that it really takes a team. And so the body is very much an integrated system. So there is no cardiologist who only thinks about the heart, and there's no kidney specialist who only thinks about the kidneys because all of these organs are in the same body. And much in the same way, the medical system itself, the healthcare system, has to be integrated as well. And so these subspecialists have to speak with each other. And so we, you know, at Stanford Medicine are always having these conversations. And so, for example, sometimes an oncologist will come to us and say, the best way to treat this kid's cancer is with an anthracycline medicine, and you have to protect the heart. And then we'll say, well, if that's the best way to treat your patient, we'll support you and we'll monitor the heart so that you can do your job. And sometimes we go to the oncologist and say, this heart is not going to tolerate that therapy. You have to find a different way. And then they help us figure out a way to keep the heart safe, where at the same time maximizing their chance for cancer survivorship. Similarly, at academic institutions, at universities like we're all practicing at here in this panel, you also have to think about the next thing. And so we're not just dealing with anthracyclines, we're dealing with next class of medications, a group called MEK inhibitors, which treat things like gliomas, which are terrible brain tumors. And together we're learning that these drugs are also cardiotoxic. And now we're seeing trickling into our clinic, and I'm sure Alfred, you're seeing them too, these patients who didn't receive anthracyclines, who are receiving this very advanced and incredibly good chemotherapy, but we're learning that these medicines too have cardiac side effects that we have to learn about together and continue to partner with the oncologists so that they can build their toolkit, they can treat cancers more effectively, and we can help them do that by protecting the organs that can be affected by those therapies.
You know, you all touched on a lot there, and it's very helpful. I think the benefits of a coordinated approach and the reasons why, you know, certainly no one size fits all approach whatsoever. But I wonder if there are a couple of insights that you've gathered in your practices and in that coordination and collaboration about balancing the risks and benefits. Dr. Hollander, you just sort of touched on that, where it seems it can be sometimes a delicate dance and balance. You know, I don't know if maybe Alfred, talking about the last couple of years as the official program has gotten off the ground, if you could sort of speak to any, you know, stepping back, any lessons you've learned about balancing risks and benefits from your colleagues in both camps, or even in, you know, outside of the cardiology and the oncology world.
Yes, that's actually is true, because we have we've collaborated with our oncology department and also our bone marrow transplant. There have been patients that have been referred for bone marrow transplantation because of recurrence of cancer that have been deemed not suitable candidates because they have decreased ventricular function. So the COG, Children's Oncology Group, and most of the Cancer Society guidelines recommend or have a guideline for using certain treatments on certain cancer patients, and that includes having ejection fraction of at least 50%. We've actually seen patients who had ejection fraction of 40% or 45% that our bone marrow transplant team have asked us, is there anything we can do? And we have brought some of these kids to the ICU and put them on Mironone infusion, for instance, to improve their ventricular function to the point that they have been able to successfully undergo bone marrow transplantation. And you know, the oncologists obviously they love to keep the patients on their floor, on their unit, because that's where they have control. If these patients are in any of the ICUs, they lose control of the patient. So they, but sometimes it's a balance of risks and also how effective the management is going to be. So sometimes we allow some of these patients to go back to the oncology unit early enough to be able to get their cancer treatment. And when we looked at follow-up, long-term follow-up after their treatment, a lot of them have their ventricular function, has actually resolved. So, but they could have been denied bone marrow transplantation if we were just following the rigid guidelines. So this is where the interplay of specialized cardiology teams, obviously partnering with the oncology team and the bone marrow stem cell transplant team can really develop effective therapies for some of these kids, so we don't deny them the services, the care that they need.
I agree. It really goes in both directions. And so one thing to know about anthracycline cardiotoxicity is it can come in two forms. So some kids, the heart gets affected at the time they receive the drug, when they're receiving their cancer therapy. And in those cases, what you want to do is stop the drug, find an alternative, and treat their heart failure, usually with medications. But for reasons that we don't fully understand, mysteriously and quite frankly, very cruelly, kids could have normal function of their heart at the time they receive anthracycline, and years, even decades later, show up and have heart failure. So most kids who've received anthracyclines, especially high dose, will see their cardiologist once a year. We have a number of kids in our transplant program who fought and beat cancer at the age of 8, 9, 10 years old, who then at 15, 16, then had to survive a heart transplant. These are incredibly resilient and brave children. And they get their heart transplants years after they've already beaten cancer. We also have kids who've received heart transplants for primary heart defects, either as babies or young children, who years later develop post-transplant cancers as a result of the immune suppression, and either have to go through chemotherapy as an already existing heart transplant recipient, or even a stem cell transplant, which we've done in a few cases. And so the relationship between the cardiac team and the oncology team, whether it's through an integrated program or not, has to be very, very strong. Because again, everything is occurring within the same patient. And so if the body is going to be an integrated system, then your healthcare system has to be an integrated system. And I think programs that do that well, like Johns Hopkins and UT Southwestern and Stanford Medicine Children Health, are really at the forefront of treating these children as human beings, not as isolated organ defects. And that's the way you want to take care of kids.
Adding to that, Seth, is also that, when we know that this partnership, now that since more survivors, more children are surviving cancers, we know that we're going to see more of this. So this is now children, we're talking about survival of 40, 60% to now almost 85%, right? 7 is now all these things, significant improvement in survival. But with that will come the burden of all these complications that can happen, right, following cancer therapy. The thing I feel that becomes also very important is there are guidelines that have been established by Children Oncology Group, the Harmonization Group, about how to follow those patients who are considered high risk for cardiovascular complications. And there you guys can go and you can look at it, our audience, you can go, you can see who are those patients, how often they should be followed, blah, blah, blah. However, we don't have guidelines to how can we follow patients that develop cardiotoxicity during that stages. So it is something that we as a cardiologist, we are literally learning more and more and establishing our own experiences, perhaps, in heart failure, how we manage those patients, and then incorporating this to the oncology population. And that is why it is very important as we continue growing and learning more about this population to collaborate on research and to see what works best for this patient population. Because at this point, still we don't know. So we have somebody with heart failure, we essentially applying the same medications that we use for heart failure for other reasons, right? But who knows if there are specific drugs that will work better in this specific type of cardiomyopathy that these patients developed. So having this coordinated approach is, I found it really paramount. In our program, I have seen a significant improvement, communication, partnership between oncology, bone marrow team and cardiology. It's a very, very beautiful partnership. When we started here, there were just 10 patients that we were following. And now we follow over 160 patients. And what we have found is one of the success of this program is this beautiful partnership that we have established. People know where to go, when they have problems. And like you were saying, Seth, also, when we have had multiple transplant patients that have developed cancer problems, the PTLD, hepatoblastoma, and other cancers, and then oncology helping us in managing these patients. So it's a two-way stuff. Yes, we see more oncology to us, but we are seeing also from cardiology, heart transplanted patients to oncology.
Yeah. And I'll add one more group to the team. I'm so glad you brought this up. This hadn't come up in our conversation yet. And this is this idea of precision medicine. And the truth is that some kids get tons of anthracycline medications and the heart does just fine. And some kids get relatively small doses and the heart gets sick. And so there has been this model of medicine that has existed for hundreds of years that everybody who gets the same disease should get the same treatment. So if person A has an infection and person B has the same infection, then they should get the same antibiotic. Now, of course, what gets excluded from that conversation? That patient themselves. And it turns out that there are many disease conditions where two people could have the exact same disease, but respond very differently to treatment. And we're learning more through genetic testing that one's genetic profile, what genetic mutations they do or do not express, will affect how they respond to medications. And the best example that I can think of as part of this conversation is anthracyclines. And there's a lot of work going on at Stanford Medicine, other places, looking at doing genetic profiling on children and adults, quite frankly, before they receive anthracyclines to predict their susceptibility to heart failure, such that hopefully sometime in the future, we'll be able to do a genetic screen from swabbing someone's cheek or taking a little bit of blood and saying, your best cancer cocktail is cocktail A, and to another patient saying, your best cocktail is cocktail B, even though you have the same cancer. And that way we can maybe prevent the heart failure altogether by avoiding the cancer medications in the specific patients who are susceptible to the side effects. And I don't think that's far along. I don't think it's routinely in clinical practice yet, but I think probably in the next several years, that'll be something that'll be an incredible tool in our ability to fight cancer and protect the heart at the same time.
Because it's just, even though in the oncology group, they are really, these people do a lot of research trying to investigate new therapies and stuff and how to minimize, the cardiotoxic medications for patients. But it doesn't seem that anthracyclines are going away anytime soon. So those are medications, cancer treatment that are really paramount to multiple cancer, pediatric cancers. So they're not going away. So while anthracyclines are being used for, in the oncology, for oncologic patients, we are gonna, we have to figure out how to mitigate the impact of this medication, because they work from cancer, they are good. So that's why, despite how, detrimental they can be to the heart, we haven't found anything to substitute anthracyclines for some of these cancer therapies.
And let's stay with that point. I'm so glad you took us there about sort of the next frontiers and what's coming. Again, thinking about this specialty being so nascent, but also coming so far in terms of just the last few years, formalizing, COG programs and that so forth. What about research, whether it's further efforts in the genetics front or the precision medicine front, or tapping into AI and all the potential there to synthesize data at the population level? Are there other things that excite you about either the work you're doing or your colleagues and institutions are doing that you could kind of point us to? And when we have this session in 5 years, we might be talking about primarily. Again, maybe Dr. Ike, we could start with you, but anyone, please jump in.
There are several research studies ongoing in the field of cardio-oncology. Obviously, most of the research started with adult patients, and a lot of research is now being extrapolated to pediatric patients. Studies are looking at cardiovascular effects of some of the newer treatments, one of which Seth, Dr. Hollander touched on, the MEK inhibitors, but there are also others like the immune checkpoint inhibitors, drugs that are called targeted treatments, such as tyrosine kinase inhibitors. All these are newer cancer drugs that can also affect the heart, and therefore there are studies ongoing to look at these effects. We also want to look at things like biomarker-driven management of these cancer patients. Adults still measure troponins, high sensitivity troponins. They still look at NT-proBNP to guide them during cancer treatment. We're not doing that routinely in kids, but that's something that is probably not too far away. There are multiple other things like looking at genetic factors to see why some kids, such as Dr. Hollander touched on, some kids receive low-dose anthracycline chemotherapy and develop cardiomyopathy, and others receive high-dose anthracyclines. Some even receive mitoxantrone, which is like one of the most potent anthracycline-like drugs, and still do not develop cardiomyopathy. So all those things, I think we need to understand this better to really help us manage these patients.
Yeah.
I hope that by developing this, as the field evolved, we are going to, as cardiologists, leading cardio-oncology programs in that regard, we can learn more from oncology. And I hope that as we partner with them, we can, number one, I think learning how to develop these registries, that they have a lot of registry data and stuff. And then, because I think we will need like a lifespan approach to learn more about this. What can we learn from this patient population, knowing that unfortunately, all these things happen later on. So it's just creating perhaps biobanks, and then we can go back and say, okay, we've seen this. That's why everything started with the Childhood Cancer Survival Study, St. Jude, they have all these patients and stuff, and then they started noticing all this effect, and they went back, and they start surveying these patients. So they have this kind of registers, all these patients. So I think we have to perhaps start somewhere there, developing registries and start utilizing biomarkers. A lot of research is going on imaging studies to detect early cardiomyopathy in patients. So magnetic resonance images, some echocardiogram parameters that we are following. Right now, for example, in our institution, we are doing a research on utilizing images to see, trying to understand better exactly what is happening in the myocardium on these patients. Tests that are non-invasive, right? So I think there's a lot of enthusiasm trying to understand what is causing these changes specifically in the myocardium of our patients. How can we prevent things from happening? Because primary prevention, I think that is where the key is. Because when they get affected, it's very hard to reverse that, right? So primary prevention, and we know right now just the dextroxazine is the only one that we can sometimes use, but more is needed.
Yeah, I'd like to build on that theme of prevention. I'm really excited about two things. One is this idea of precision medicine. So this idea that everybody's personal profile will be used to prevent complications. Since so much of what we do as doctors is curing the primary disease, and so much of what we do is preventing the side effects of the cures of the disease that we do. And as important as that is, that's playing defense, right? Preventing cardiomyopathy in a cancer patient is playing defense, and that's really important. I'm equally as excited about playing offense and preventing these things altogether, just like Dr. Hernandez says, particularly in the field of post-transplant. And I think this collaboration between the oncology groups, particularly the stem cell groups, and transplant professionals like myself, to modify the immune system at the time of heart transplant, such that a patient can tolerate a heart transplant without any immunosuppression and never run the risk of a post-transplant cancer because they're no longer at risk for it, such that we're playing offense and we don't have to cure disease in the future because we prevented it from happening in the first place. That's really, really exciting. And the fact that we've already done this at Stanford Medicine in a couple of kidney patients, and we're exploring it in heart patients, such that hopefully over the course of my lifetime, we'll see more and more solid organ patients on no immunosuppression and therefore not at risk for those things. That for me is equally as exciting as all of the precision preventative stuff that is currently happening.
Our time is running short, so I want to march us through a couple more questions if I can. This is one that you all have sort of, expressed and touched on, but just to ask it more directly, it comes from a member of our audience. How are you working with care teams for those survivors who, are aging well past the age of 18? And again, I know that's there's so many different answers to that question, but I wonder if there's kind of a couple of key takeaways there that you could share about something that was effective for someone or anything like that. Anyone want to jump into that?
Personally, in my experience, so the way that we are doing is because there is something important, it's called transition of care, right? So our oncology team, they usually, once patient become an adult, they can transition when, 19, 21 years of age. But now that we have developed this program, we partner with our adult cardio-oncology from the UT Southwestern. So when I have any patient that have any cardiac problem already, and I know it's a very high risk, so I have at least we have the privilege here at university hospitals that we can transition them to an adult cardio-oncology. One thing that is also very important to highlight, we have nurse practitioners, the oncologists, the oncology side, they are amazing, and they run the after cancer experience clinics. So and then they also see patients in the adult side. So it's a beautiful continuation of care in that regard. But I get concerned is, patients that cannot go to UT Southwestern or they are survivors, and then what about who take care of them in the community? Who makes sure that they are followed properly? They are not lost in translation when they are more vulnerable. Perhaps when they become adults, they might lose insurance, and all this stuff. So that's so from our standpoint, we have this partnership where we transition our patient smoothly without any problem, of course.
So this is, I just want to add a couple of sentences to that. So it works beautifully when you have a big university teaching hospital that has a pediatric wing and an adult.
Mhm.
Now, if you have a freestanding children's hospital like we have, it is very difficult to transition. I'm still seeing some patients who are, 22, 23, 24 years old, just because they are not able to transition because they have other issues that are not easy for them to transition into adult hospitals. Like if you have a kid with a significant developmental delay, it's very difficult for them to transition. So while we're partnering with our adult colleagues, it is not as easy and it's not as straightforward.
Yeah. The movement from pediatric to adult care is really a moment to be celebrated. We've largely abandoned the term transition, and we now use the term graduation because we want it to have a celebratory aspect. We say you're graduating to adult care. However, the other side of that coin is it's a time of high risk, and there's overwhelming number of research studies that show that the period after graduation to adult care, regardless really of what your disease condition is a period of high risk when young adults are learning how to be adults. And although the official recommendations are that young adults should transition between the ages of 18 and 21, just like Dr. Asante-Krang said, not everybody at 21 is ready to be an adult. We all mature at different rates, even if we have normal cognitive function, and certainly if we have cognitive delays, it's even harder. And so, we'll take care of patients until 24, 25, 26 if we have to, and we really try to prepare them for graduation in a stepwise way. And there are now a number of tools to assess whether or not a young adult is ready for graduation. And a lot of literature to really emphasize the need for support during this particularly high risk, but at the same time, very exciting time in their lives.
I want to slip in one quick question and then one leave room for final thoughts from each of you. Dr. Baez-Hernandez, you alluded to kind of questions and challenges of access. And again, I know when treating folks in rural communities or as they age and maybe become disconnected or are in the hospital less frequently, which is a good thing. What are some of the ways that the challenges there? I don't know if one of you could just sort of kind of give a couple of examples of things that those of us in our audience might be mindful of, especially if they're representing a rural hospital or an institution that sees a lot of patients without insurance or anything like that.
So one of the things that we have incorporated to our program is our social worker, right? So that person that can help us to streamline and that graduation, like Seth, I like that terminology, the graduation from a pediatric program. So incorporating somebody that can help navigate when somebody has some problems graduating. However, one of the things that I have found very important is as we have, advanced this program is connecting with other people outside there in the community. And it's important to continue doing this webinar and all this stuff because people get to know you. I have been approached by other providers from different institutions out in the community about, some patients that might not qualify for insurance resource to go to an academic institution from this pediatric program to an adult program, like I was telling our colleagues, adult counterparts. So now how can we transition this somewhere else? So I think these webinars are very important because people get to know you and they get to learn more about your program and you can work easily with families. But I think it is, I find it's very useful having a social worker working with us to help with that.
We're right about at time, but again, I want to make sure you each have a moment to share sort of a final thought or takeaway. A lot of ground we haven't covered, or is there anything that you'd want to share with your fellow care providers on this call, with parents and families, or anything like that? Either to underscore something we talked about, or to slip in a mention of something we haven't. Dr. Hollander, maybe we could start with you, and then others.
Sure. I think the theme, at least of my contribution today, is real integration of care. And that we need to be thinking of patients as whole systems, and we need to conform our healthcare systems to treating patients as their whole selves, not as as holders of our specific organs that we specialize in. And I think when we think that way, like Dr. Asante-Krang, Dr. Hernandez do at their outstanding institutions, and the kids get great care.
Dr. Baez-Hernandez?
Well, it's the collaborative approach is significantly important as we take care of this patient. It is everybody working with the same purpose of making sure that they have a successful cancer treatment and life after cancer treatment.
And final thought from you, Dr. Asante Kareem?
I think these are very vulnerable patients, and I'm scared. I'm scared because of funding and issues with access to care, especially for underserved and patients who do not have ability to pay. I'm worried that as Congress continues to debate budget reconciliation measures, that Medicaid and children's health insurance programs are not, the programs that suffer from lack of funding.
Well, thank you all for your time, for all these insights. I know we fit a lot into a short amount of time, but I want to thank those of you in our audience for joining us and for your attention. And I want to give a special thanks to Dr. Alfred Asante Kareem, Dr. Nathania Baez Hernandez, and Dr. Seth Hollander for sharing their insights with us today. As I said, look out for a follow-up email with video from today's session, and you can always find more coming up from US News Live at usnews.com/events. Thanks for being with us.